Good morning. My name is Beverly Vandiver. I'm the Interim Executive Director for the Kirwan Institute for the Study of Race and Ethnicity. And I want to welcome you this morning to our webinar panel. During the previous panel, we highlighted ways that people individually have pivoted their focus during times of talent or to cope or even thrive during the pandemic. During this session, we want to move beyond the responses of personal development to continue talking about structural and systemic changes that can better enable women and families to rebound from the destabilizing effects of COVID-19. Although the public discourse is often recommending a return to normal or adapting to the new normal, we need to pause to recognize how the status quo, both before and during the pandemic, has disproportionately impacted women. Now's the time to envision policies and practices that address the gender inequalities in housing, financial security, health, caregiving that were merely intensified, not created by the pandemic. So at this point, what I'd like to do is to get started by first introducing each individual panelist, and then we'll begin to sort of engage the panelists in questions. Sorry about that. So the first person is Dr. Rhonda Vanshay Sharp. Dr. Sharp is an economist and a mathematician who analyzes large data sets to find the stories hidden in the aggregate. Her research shows that by disaggregating data, that we can identify the nuances in the Women's Institute for the nuances in outcomes that can improve economic well-being. She is the president and founder of the Women's Institute for Science, Equity, and Race. Her research has been featured on the PBS NewsHour, Marketplace, and the Carrie Miller Show, and in the New York Times, The Economist, and the Washington Post. Welcome, Dr. Sharp. Our next panelist is Dr. Lauren Jones. Lauren Jones is an associate professor in the Department of Human Sciences and the John Glenn College of Public Affairs at The Ohio State. She conducts quantitative, policy-based research on child and family well-being, especially in the areas of consumer protection, social policy, and health. Broadly, her interests lie in understanding factors that affect the ability of children and families to flourish and how government policy can help families get ahead. Thank you for being here, Dr. Jones. And then we have Margaret Graham. Just looking to see if there's a Dr. Graham. Okay. I have the wrong name here, so I don't know about Dr. Graham is Vice Dean and Associate Professor at The Ohio State University College of Nursing. She has served in the U.S. Public Health Service and has worked with underserved communities as a family nurse practitioner in 6 states. She believes that RNs practicing in public health or community-based primary care at the top of their scope will be leaders in solving the healthcare challenges related to chronic disease and our global pandemic. Throughout her nursing career, she has been committed to educating nurses to increase their knowledge, skills, and abilities to provide care for the underserved. Welcome, Dr. Graham. Now, let me just turn to the kinds of questions. So as I mentioned before, we're talking about going back to the moment of the early pandemic period of spring 2020, and how people experienced the shutdown varied based upon their gender, race, and ethnicity, and occupations, among other factors. Some people only had expected a brief shutdown and were sort of relishing that time for greater productivity, or they were posting on social media, friends, baking bread, taking up hobbies, streamlining their closets, buying expensive things like the Peloton bikes, and just spending more time with families. Yet the possibility of making the most of this time varied on individual identities and level of privilege. So there were a number of women who were predominantly working in service industries and healthcare. And then there were others that were working in highly exposed areas of risk. So early in the shutdown period, the Women's Place disseminated a survey about attitudes and experiences of remote care. Caregivers, especially parents of preschoolers, attested to the additional stressors they faced. Meanwhile, some Ohio State employees from minoritized backgrounds noted that one benefit of working from home was being able to avoid some of the microaggressions that they usually encountered. So in the office. So Rhonda, I'm going to turn to you first, and I'm going to ask you, what do we know about who benefited or not from remote work? How does disaggregating data help to tell a fuller story of the impact of COVID-19's disruption and continuing inequities?
Good morning. Thank you, Beverly, for that question. And I want to thank the Women's Place for the invitation, and to my good buddy, Nina Banks, for recommending me. So I'm going to start with what's probably the obvious, but the one that we don't think about. And I'd say that who benefited from remote work first and foremost were employers who could actually shift to have their services provided remotely. And I think so often when we have that question, we want to think about the worker and not necessarily the employers who were able to benefit. Now, if we move from the employers to the employees, and I also want to sort of pivot back to something that you said when you said about level of privilege. And so often that is attached to household structure and level of education, whether or not you're in a single household as myself, or you have an additional person, whether that is a spouse, a parent, but there's another body in the home. The interesting thing about remote work is we generally don't ask questions about it, and it's very difficult to get a feel for who that is. So the census has what's called the Household Pulse Survey, and they collected data about who was teleworking. And I thought this was very interesting because they're not asking that question anymore. They only asked the question from August 19th through the 31st, 2020. That was the first time they surveyed. And then they stopped asking the question September 29th, the week of September 29th, to the first week of October 2021. So there is this perception that suddenly telework has gone away. But here's what I can tell you in terms of looking at the data on telework. People who are married were more likely to report that someone in their house had access to telework. And that's about somewhere between 30 and 40%. When we come and take a step back and look at this by race, let me start with gender. Look at this by gender, surprisingly, or not, right? Because if we think about occupation segregation, that women tend to be in more front-facing service positions. And I suspect Margaret will talk a little bit about this, being in the School of Nursing, whether it's nursing, teaching, retail, women are in more front-facing positions. So men were more likely to report having the option to telework. And then we find households married with children more reported having access to telework. And that is something that I really want us to think about on this panel. And that is when we're talking about women and getting women back to work. I noticed that I believe her name is Erica Harris, I think mentioned it on the last panel about being focused on moms. Personally, because she is one, I'm not a mom, I'm not married, and I am always concerned in these conversations about women, what's normal, policies to get folks back to work, that we forget about single women. We forget that often many of us are shouldering the burdens of care because people have kids, are married, that it comes to us. So ultimately, what I want to remind us is the main beneficiary of remote work were employers who could actually shift. And then what we find is folks who report having access were more likely to be married, have children in their homes, and men.
Thank you, Dr. Sharp. Dr. Jones, I'm going to pivot to you and talk about, as we talk about daycares and schools closed, the pandemic disruptions exposed how few safety nets we have in the U.S. to support families, and especially in comparison to other industrialized nations that have parental leave and greater care subsidies. How did the pandemic expose the gaps in the American child care system and in supports for caregivers?
Thank you, Beverly. And yeah, thanks very much to the Women's Place for inviting me. Very excited to be here on the panel. So, I think the biggest thing that became apparent during the pandemic is that we place a very low value on caregiving in our society. We really rely on a patchwork of supports, and I hate to even call it a patchwork because for me, that evokes like a beautifully well-made quilt. I'm thinking more of like pieces held together with duct tape situation. But a patchwork of schools, daycares, and additionally unpaid domestic labor of parents who wind up being primarily women to keep our economy running. So, I think the low value we place on care is reflected in a couple ways. First, I'll give you an example. Imagine two households with children, both making $75,000 a year. One is a single parent household, the other a two-parent household with a single earner. So both cases, it's just one individual making the $75,000 salary. The single parent household is going to have to pay for childcare in order to continue earning their wage, whereas the two-parent household is relying on the care of the second parent to take care. So those households are going to be treated equivalently under our tax code, even though the first single parent household has this additional cost they're going to have to pay. And when we're thinking about kind of the equity of a tax system, that's kind of a gap in the sense that we don't have what we would call horizontal equity. These two families that have different ability to pay taxes are kind of facing the same tax liability. So, I think that really kind of illustrates the fact that we're essentially valuing the work that second parent is doing at zero within our tax code. The way that kind of, I think, comes out in the wash is that the low value we're placing on the care within the household is really being translated into low value that we're placing on care provided outside of the household in professional childcare and early childhood education settings. So we have a kind of resulting industry of the early childcare workforce, which is, disproportionately women of color who are being, essentially paid like very low wages to do work that some people in our community still view as babysitting, as opposed to what it really is in educating our children. So there's a huge body of research indicating that experiences that kids have in the first 5 years of life shape their outcomes for the entire trajectory of their life. So, it really doesn't make good sense for us to be putting such low value on the experiences that are happening in that early, the early part of our kids' lives. So we wind up with this very precarious workforce, as I said, disproportionately women of color, who are undercompensated. So the average hourly wage of women working, or people working in early childhood in Ohio is $12 an hour. It's kind of hard to believe. These are women who we've seen during the women and workers who we've seen during the pandemic are kind of putting themselves at risk every day to show up and do one of the arguably most important jobs in our society, which is taking care of our children. I think the pandemic really revealed that this workforce is the glue holding our economy together. And that, this is, I'm sure many of you have heard this, but this argument that childcare is infrastructure. So, to get back to your question, Beverly, we're really in a particularly bad place here in the US because especially compared to our neighboring and kind of comparable countries, we have an astoundingly low level of public investment in early childhood. We do not fund early childhood. I think that's kind of coming out of these same ideas of having really low value on early childhood. And we're really not kind of acknowledging the negative impacts this has on kids, the negative impacts it has on businesses, and most importantly, the negative impacts it has on families and the people who are doing childcare in those families which end up being women. And that's something we've really seen during the pandemic, that, the disruptions in childcare that have come from the fact that we have this, very weak patchwork of programs in place has really disproportionately affected women's ability to rejoin the workforce in the way that they want to.
Thank you, Dr. Jones. I'm going to just redirect you a little bit or get you to expand a little bit more about, during the pandemic, the federal government issued 3 rounds of the stimulus checks of economic impact payments. And then there's this larger Build Back Better framework that continues to be in limbo. What do you think is the impact of these initiatives like short-term stimulus checks versus tax credit? You mentioned a little bit about the tax credit on the economic well-being of families.
Yeah, thanks for the question. Yeah, I think it's always good to give families cash. I mean, everybody likes getting some cash in their pocket. Giving families cash, especially under-resourced families, is good policy. Research documents that they spend the money on things that we generally think are kind of, good things. I put that in quotation marks because I think there's a really, problematic paternalistic view or paternalistic attitude in the way we talk about low-income families and the way we expect them to be spending money. But, I think in terms of the kind of stimulus checks, they're great.
Mm-hmm.
I'm going to make a case that the tax credits are better. The tax credits are targeted. So when we live in a kind of, low resource world where it's difficult to raise money for these types of initiatives, we're better off spending the money on groups that we think are going to benefit the most from the money. In this case, lower income families, lower resource families with kids. The other great thing I think about the tax credits is that they're predictable. So, especially the expanded child tax credit proposal, where a portion of the tax credit money, rather than receiving it in your tax refund, was given out on a monthly basis. That can really help families be able to predict and kind of plan their spending, their labor supply decisions, and their childcare needs over the course of the year, rather than kind of relying on these, in the case of the rebate or the stimulus spending, these unexpected one-offs, or even in the case of the earned income tax credit and the way we typically pay out the child tax credit, these like huge payments one time a year, even though some families do prefer that approach because of the fact that it offers them a way to save money in order to buy a car or something like that. Many families spending money on a car. But I do think the real beauty of the expanded child tax credit proposal was that it was paid in installments, which allowed families to kind of use the money to meet their day-to-day needs and plan. And then I'll just finish by saying the child tax credit, I think it was really billed as this revolutionary thing. We are such laggards compared to our neighbors and our kind of comparable countries. Implementing the expanded child tax credit in a permanent way would not be something revolutionary compared to what's going on in other countries. It would really raise us to meet the bar that's set and met by most, if not all, of our peer countries.
So well stated. I'm going to come back to you, Dr. Sharp, and Margaret, Dr. Graham. I have not forgotten about you. I have questions for you. I'm going to come back to you, Dr. Sharp. Given what Dr. Jones has been talking about, what kind of policies will it take for working women to rebound from the economic turndown of the pandemic? What are the barriers to these changes?
So I'm going to start with, we first need to disaggregate who we're talking about when we say women. Because so far, again, this conversation has been very much focused on mothers, families, folks with children. And before I go answer that, I want to comment on something that Lauren was talking about with respect to the child tax credit. And the thing that troubles me around this policy is the way that it's evaluated. That when people talk about it as being such a great thing when a family moves out of poverty because of the tax credit. And I always snickle at that because I am just like, are you kidding me? A penny above the poverty level, and you say suddenly my life is great. And I know great is an exaggeration, but I am troubled by this notion in terms of looking at the child tax credit and moving folks out of poverty, that it is not a conversation about moving people out of the experience of poverty, which is something that is very different. So having said that, coming back to what you've asked me, I think the biggest thing is to be very clear about who we're talking about in the pandemic. What women are we trying to help? Are we looking to help those of us who are highly educated? Are we looking to help folks who are in front-facing positions? And if we are talking about people who are in front-facing positions, especially those who are hourly workers, potentially not as educated, I think that's going to be more of a challenge, because what we don't talk about these workers are the ways in which they have now become invisible again. Right? If we can remember at the beginning of the pandemic, all of these folks who were front facing, how we were so thrilled to see our cashiers, and there was a conversation about essential workers. And I would often remind people that there's a difference between being an essential worker and being an expendable worker. And some of the women that we're talking about getting back to work are expendable. We really don't care if their lives are at risk in terms of getting their jobs done. So I think that is a huge barrier, that services that women provide are often viewed as in some way sense of entitlement. Like there is an expectation that my cashier is going to be there. There is an expectation that my stylist is going to be there. There's an expectation that if I get sick, that there is going to be a nurse there. And even in this conversation about disruption of childcare, that is a conversation that is so wrong, because this wasn't a disruption about childcare, because childcare and schooling are not the same thing. And I educate on the higher ed level. And I know that those of us who consider ourselves professors cringe when folks call us teachers. So I can only imagine how teachers feel when people conflate their services with childcare. It's not the same conversation. So I think that the biggest barrier to getting any of these policies changed, and at the Women's Institute for Science, Equity, and Race, we really hammer, it is important for you to talk about, name who you're talking about, right? Not women of color, Asian, Black, Hispanic, Native American, multiracial, transgender women. Who are you talking about? Because if you don't name the group, you can't target a policy to help them. And I think that's going to be our biggest barrier. It's not necessarily anything about the economy. It is going to be our willingness to be critical, thoughtful, and inclusive about the analysis that we do, so that we can get at the nuances and craft appropriate policies.
You got me on board. I was going to, like, you're preaching to the choir, but you're ready to say hallelujah, because I think that there's just so many components of that. And you're right about trying to figure out those barriers, and you can't get to those if you don't know who you're talking about. Dr. Graham, I'm going to turn to you, because we have been talking about the economic effects of COVID on women and their careers. But of course, we have to think about the pandemic in terms of the gendered health effects as well. What have studies been showing about how the coronavirus have had an impact on women's physical health?
Thank you very much, Beverly, for the question, and thanks for the opportunity to be here. In anticipation of your question, I did pull some data. So if you'll bear with me just a little bit to share some numbers with you. We know that women have more cases of COVID, but men have more total deaths of COVID. So there was a study that was done, a 55-week study that ended in November 29th of 2021. And if we look specifically at Ohio, of the 1.6 million reported cases during those 55 weeks, 63% of those cases were women. And then when we look at the total deaths during that time, which was 26,483, 46.5% of the deaths were women. And this holds up true nationally, that we see more cases in women, but more deaths. And some people say more severity. I'm not sure that I could say that we could say that. But if we look at long COVID, more women have long COVID, and that's going to really give us a challenge, I think, for we're talking about employment of women. And that some studies are suggesting 60%, but there is a COVID Human Genetic Global Consortium that is looking at many aspects of COVID, and the person who's leading the long COVID arm of that says that he anticipates long COVID may be more 70 to 80% of women with long COVID compared to men. Prevention care was a problem we know during early COVID. We had to really stop doing a lot of the care we gave because we didn't have enough PPE. Some of that certainly got better quick. And then once we got immunizations, we started seeing some better things related to that. But we know that women skipped their preventative services more, 35% compared to 26% of men. And women were more likely to skip recommended medical test and treatment, so 23% compared to men. But I think something that's really concerning is that women who consider themselves in fair or poor health, 46% of them skipped their preventative care, and a third of them skipped their test and or treatment. But if we think about people who consider themselves poor health, we know that the severity of COVID is much greater in people with poor health. So the concern of them leaving their home or wherever they're residing could play into this. But we think that this will probably give us challenges for those care gaps for some time. In pre-pandemic times, we know that women who had less resources were less likely to do preventative care. Interestingly, though, during the pandemic, women who were greater than 200 federal poverty level, women who had private insurance, or women who had Medicaid were more likely to skip care than those who had less access. And many people think, again, that that had to do with concerns of COVID exposure going for that. When we look at reproductive care in 2020, in the summer of 2020, that was pre-vaccine, we saw an 86% drop in GYN care, a 63% drop in contraception visits, a 52% drop in sexually transmitted infections, and there was an 83% decline in pap smears. That got a little better. There was a study that was administered in July and August. And so that was after vaccines came, and we saw a smaller impact on reproductive health, but we still see quite a disproportionate effect on those experiencing systemic and health inequities. Women's changed their fertility plans. 41% of women in 2020 said they changed their fertility plans. And that's compared to 22%, but that's still more than a fifth of the population in 2021. It was interesting to me that 15% women said they wanted fewer children or to delay having children, but 11% wanted to have more children. And I found that a little interesting. Some of the women who wanted to have more children said that they were working from home and it just seemed to be a good time. And so maybe they were doing it a little earlier. Regarding pregnancies, based on what we know so far, pregnant women and recently pregnant women have an increased risk for severe illness from COVID-19 compared to non-pregnant women. And the Delta variant that we had in the fall of 2021 really brought a disturbing increase in stillbirths and maternal morbidity and mortality. And so as we look at the risk of pregnancy and post-pregnancy, we also, and we've accumulated a lot of data, we've also accumulated a large amount of data on the safety of vaccines. And so we have to, I think, address misinformation because that's been something that we are all dealing with. And so the Kaiser Family Foundation did a survey on November the 8th of they did it in October. They reported on November the 8th of 2021. And they used 8 false statements. And 80% of US adults either believe one or at least one of those false statements. And about a third of our population adults believe 4 of those false statements. And so I pulled out 2 of those false statements that I think relate to women. Well, one relates to everyone, but one is about 17% of the respondents said that they have heard that pregnant women should not get the vaccine and believe that to be true. And an additional 22% are familiar with that statement and they're not sure if that's true or not. So that's a total of 39%. And if you think of people who are getting advice from their family, their members, who believe those statements, I think that that's a real challenge for us with this information. Another one of those 8 questions is that 8% of the respondents said that they've heard that the vaccines have been shown to cause infertility and believe that to be true. And 23% have heard it and they're not sure if it's true or not. So again, that's like 31% of the population. We've all heard a lot about mental health, and one survey shared that 51% of women and 34% of men say that they have worry, stress related to the pandemic, and that has affected their mental health. But a fifth, 21% of women and 17% of men say that it has taken a major toll and has been a major impact on their health. And we have seen the U.S. has experienced the highest number of overdose deaths in the months related to the pandemic. We've seen the rate of substance abuse in pregnant women has increased. We all know, we've read about the alcohol sales and consumption that have increased. And RAND has done 3 different surveys related to drinking, and they did find that during the pandemic, women have increased their heavy drinking compared to pre-pandemic days. And we know that people who have substance use disorders really need a lot of care and a lot of support. And the pandemic has been so isolating that's really interfered greatly with this. So there are, I'm sure, many more changes that are associated with women, but those are some of the ones that are highlighted that we see and hear a lot about.
Thank you for those summary, because there's a lot of data out there and it's going to continue to grow. I'm going to transition from what we know the impact of COVID has been for women to solutions for help. And I know that your work has focused on advocating to make telehealth more accessible. During the pandemic, initially the insurance companies had previously excluded coverage for telehealth appointments and then began to include it. How could telehealth address disparities in healthcare access, or as well as what are the limits of telehealth as a way of closing these access gaps, especially for people in low income backgrounds, and especially in light of what you're talking about, the significant drop, even with people in insurance, of even going to appointments?
Well, you're right. I've been interested in telehealth for a long time, and the College of Nursing, we operate a federally qualified health center at OSU East, and we were delivering telehealth on a limited basis prior to the pandemic, and the challenge was reimbursement. And I will say the one thing, I know there are other positive things from the pandemic. It's hard to see those sometimes when you're in healthcare, but one of those is reimbursement for telehealth. And almost overnight, we started seeing reimbursement for healthcare providers for providing telehealth. Medicare generally is we say as Medicare goes, so goes the nation. So Medicare, Medicaid, we started getting reimbursement. At our federally qualified health center, we were able to give our pregnant patients who are there for prenatal care, we were able to give them Dopplers, we were able to give them blood pressure cuffs, scales, so they could take those home and we could help monitor them at home and have telehealth visits. Now, you still have to have some visits, but that, when we're thinking about the risk to these pregnant women of exposure, that's a significant thing. Our patients have difficulty, not all, we see patients from across all socioeconomic, but we are a federally qualified health center and we are really there. And we do a lot of service for the underserved. And prior to the pandemic, the major reason we had for no-show appointments was transportation. And once we went to telehealth, our no-show appointments dropped by 15%. And it's because people had access. Now, those are positive things about it. to have telehealth, you have to have broadband or you have to have some access. Telephones are considered telehealth, but it's not the same as having face-to-face. And so a person needs a smartphone. They need to have enough minutes on a smartphone to be able to have a visit. And so that can make a huge difference for them. Our mental health, we have a psych mental health nurse practitioner. Our mental health really, we have such huge needs in mental health, and telehealth can really address that in a great way. And so we have to think about our non-English speaking patients. We have to be able to bring in a third party. At the Total Health and Wellness, we do have telehealth, but we can bring a third party. You have to have an interpreter. If you have a patient there or a patient at home and they're having to use their child as their interpreter, they lose their privacy, so we need to have good interpretive services as we do telehealth. But telehealth really, I think the access that telehealth can give, especially in the management of chronic disease, when we look at the management with diabetes, if we can supply digitals for our patients so that they can check some of these things, I think we can start getting our hands around chronic disease management. We've got to make sure that every single provider practices I'm a nurse practitioner, so I think we have to make sure every single provider practices at the top of their scope. We have to have policies for that. Pharmacists have to, psychologists have to, nurse practitioners, nurses, we all have to be practicing so we can start getting our hands around the challenges that we have in this country with chronic disease. Because the challenges we have with chronic disease have been magnified with the outcomes that we've had with our COVID pandemic.
Thank you, Dr. Graham.
Mm-hmm.
I'm going to pivot a little bit because we're beginning to run out of time, and when I'm going to open up a general question for all of you, and if you can if you want to respond briefly. In sessions like these, attendees will always want to take away action, to be clear about what it is that they can do to begin or to continue advocating towards gender equity. What do you recommend that viewers prioritize to make an impact? What's the takeaway message based upon each of your areas of specialty? And I'll open it up for either one, any of you to respond.
I'll respond quickly. We need to continue our telehealth and enlarge our telehealth so that we provide greater access. And we have to make sure every single healthcare provider is practicing at the top of their scope.
Thank you. Lauren or Rhonda?
I'll jump in. I think we're at a really special time right now where, segments of our society that don't typically think too much about childcare are thinking about childcare. And I'm talking, in particular, business community and more business-minded politicians. I think we really have some momentum to be able to push for some of the parts of Build Back Better that were specifically targeted at childcare, for example, passing universal pre-K policy. So I would recommend, my suggestion would be to do whatever you can to help our lawmakers know that that's a priority for us here in Ohio and wherever you are. And of course, just continue everyone's work in dismantling the patriarchy as well.
Thank you, Dr. Jones. Dr. Sharp?
I'm probably not going to be that short, but I'm going to do my best to be succinct. I want to start with first asking people to think about the ways they oppress others. Both Christina, and hopefully I wrote her name down correctly, Vera Reed and Erica Harris, and I'm sorry, I forgot the other woman who I think is at Ohio State who was talking about professional development initiatives, mentioned moms, they mentioned women, they mentioned support. But I don't think that we often think about the ways in which women oppress other women. So I mentioned early on that Nina Banks recommended me to be here, and both Nina Banks, who is at Bucknell, Michelle Holder, who is the president of or executive director of Equitable Growth, had mentioned that white women and sometimes educated women more broadly oppress others because we utilize them for our service and in ways of taking care of our children and our homes. And so I think that's really important, is that we think about the ways in which we oppress. Second is to be critical about how data is presented. So as I listened to Margaret talk about all the COVID data, in my head, I was going, what women are we talking about? How does this look if you are not just a woman, but you happen to be a Black woman or an Asian woman? And it always strikes me as odd, because when I say that, people sort of look at me without thinking about the way COVID data is reported. It is usually recorded in age categories. It is reported by gender. It is reported by race and ethnicity, but we do not see that reported at the intersection. And that is important because there are certain groups like Blacks who get sickle cell, and then getting COVID is problematic. There are Jewish folks who get PSAC, I think that's right. And so that might be problematic, but we don't see the data reported that way. It is reported generically as women. And I don't know who you're talking about, tongue in cheek, or how we get appropriate policies. And then I think for me, the biggest action, because again, at the Women's Institute at Science, Equity, and Race, we are going to beat folks together with to death with disaggregating data. It's to disaggregate data when you report it. We all want to see ourselves in the data, unless it's bad data. I've learned that, right? Bad data, we don't want to see ourselves in that, right? We're like, no, thank you. But we need to see ourselves in the data. So as I believe Vanessa said to me in the chat, so that we feel seen, so that there is more inclusion and we can get policies that are tailored. And I think that's the thing that I'm really not sort of hearing us have a conversation about. We need tailored policies for the groups that we are trying to help. And then lastly, I would ask people, there's conversation about who or what you center. I'm going to ask that we not center individuals, but we center vulnerabilities. Because when you center the vulnerability, you force generically, in the larger sense, America to think about the structures that are in place that cause people to be vulnerable. When you center individuals, it is easier for us to blame them for all the reasons and ways and whys and fill in the blanks for why they are not whatever they are. So I'd like to see people think about how they oppress, disaggregate data, and center vulnerabilities. Those are my takeaways.
Wonderful, wonderful. I'm going to ask another general question that's coming from the audience. When addressing changes that work for women, we often hear it's going to take time, which means that they ultimately turn into piecemeal actions. What are some high impact institutional and structural measures that can be taken now?
I'll jump in just to, not to beat a dead horse, but childcare. I think everything Rhonda's saying about, thinking how our actions as white women, as women who have high education, et cetera, are impacting other women. This childcare policy that is currently potentially going to be passed for our entire country can address that issue. And also the other side that we've been talking about, how do we facilitate women's involvement in the labor force? So my view, this is kind of like the moment for this policy that could have amazing impacts, both for this highly, female dominated labor force that we are relying on and chronically underpaying to do our labor. So more educated, higher wage women can go to work, so they can be appropriately compensated. And so, women across the income distribution can, do the thing they want to do, which is, continue contributing to the society in the way that they feel works for them the best. So, I really think this is a moment where we could have broad reaching, big change if we can kind of get our act together as a country and get some of this legislation passed.
Thanks.
I think to pass legislation, we have to be involved with our legislators. We have to know who they are. We have to educate them. We have to let them know. I think legislators in general want to be good servants to their constituency. But I wonder how many of us are very involved with our legislators and letting them know where their constituency and what we need related to all of the needs that we've discussed today.
So,
And
go ahead. Go ahead.
I think that I would add in there is for us to encourage women to take risks, right? That I think this is a time where people can step out and hang their shingles, and we need to be encouraging more folks to do that and then supporting them when they do. And that doesn't necessarily always mean that I buy from your business, but it may mean that I make sure that you're eating today because I know you have taken this risk and income may not be steady, right? I think that's the biggest, because when women take risk broadly, there is some little girl watching you who will then be more willing to take a risk. She won't see that her paycheck is always going to be dependent on the structures of corporate America, that she knows that she can step out and follow her dreams and her passions.
Thank you. When y'all were all talking, one of the things that came up for me, and I had a question about it, is this idea of trust and vulnerability and values. And I heard across some of this is that what is the value of all types of women, and what are the values of different type of women and their role in society? And that just sort of hit me like a ton of bricks to think about the fact that childcare is one of the biggest barriers for various women, especially low-income women, to be able to go to work. Or people wonder why part of our economy is based upon the shrinkage of people going to work, and if you don't have childcare, well, it's going to be better for me to stay at home for my children. So I'm wondering, what would it take to galvanize women to see what I think you said, Dr. Sharp, the vulnerability of all women, for us to really create a coalition that would really do what Dr. Graham is talking about and bombard the legislators with this need that would improve the general health and economy for all.
So I'm going to jump in on that one first and say that I think one of them is to recognize that my being a woman is not defined by what my womb produced. And I think so often that is the conversation, even when we're talking about childcare. And I love that there's a comment about single people and policies. There aren't policies for me in professional development. There aren't policies for me if I provide childcare, but that's not my child, right? I'm sure that there are a whole bunch of biological aunts and aunties, right? Because we all know that friend that you're taking care of. And there isn't consideration for the ways in which we provide care, that we as single people may also need policies so that we can be supportive for folks in our circle. So I would say the first is you can't bring a coalition together if you judge me. And let's really be honest. If you are single and you don't have children and they're not on your radar, we are being judged. People don't want family policies. Often they want maternal leave policies, right? Not just for anyone to provide care. So, if you're going to build a coalition, I think that it starts with recognizing that all of us have care responsibilities. They may look different. Whether or not it's literally the person in your household or you're going to someone's household to do that. And again, minimize the ways in which we are judging people decisions, because you might need that person like me who doesn't have children, right? But who can pick up so much of the slack so that you can be there having that conversation with the legislator. I might be the person who's sitting back watching your kid. Right. Yeah. So let's be really clear about who we're defining as women and don't make that about my womb.
And interesting enough, someone just wrote in a question for you, Rhonda, about that. She often worries that on top of everything else, she's focused on the need for childcare and flexibility, and worries that it places an unfair burden on her female colleagues who do not have children. And so she's asking, do you have any suggestions for specific ways, I guess, at an individual to acknowledge and that address it on individual level? She says, I really hear you.
You know, I don't, because I made a conscious decision not to make children. And, you know, full disclosure on my end, I chose to have a tubal ligation. And then let me tell you all, realized that I had chose to be sterilized, and that hit me like a ton of bricks because I had not associated that with sterilization. So in my case, I often give time because I do have that time, because there isn't someone else in my home, right? This is how I get my share. I tell people I treat kids like library books. You know, you check them out with the expectation that you return them at a given date in the same condition, right? That is my service to my community, that I will look out for your children. And I think every now and then, just to acknowledge, to tell that person, like, I appreciate the ways in which you pick up the slack because I go home early, right? And you know, and here's something simple, like, here's your favorite piece of candy. I brought you a muffin. I brought you some coffee. Like, it doesn't have to be grand gestures. You know, again, what is showing up so much in the chat is we want to be seen. We don't want to be devalued because we've made choices that aren't about children. Just a thank you is often enough.
Thank you for that response. We're coming toward the end of their time, and I just wondered, Dr. Graham or Dr. Jones, if you have any remaining thoughts that you want to share before we close out the panel.
No, I don't think so. I've enjoyed it. I've enjoyed being on the panel with everyone. Thank you.
Yeah, I'll just thank Drs. Graham and Sharp and for the great conversation, and Dr. Vandiver for moderating and giving us such great questions. So appreciate the time being here.
Well, I've appreciated being involved in this, and I think it's a conversation that needs to continue. And I'm glad that the Women's Place have sort of launched more of this, because I know they've done the survey, and so they're monitoring these situations. And I think, as we all know, the pandemic has laid bare the challenges, as you mentioned, Dr. Jones, that have been here in terms of the patchwork of healthcare, the patchwork of not acknowledging the economic burden of various women. And so I think that, you know, the more that we can sort of highlight these challenges, and hopefully for people to start thinking more about women of all types and diversity contribute significantly to the life force and the economy of the United States. And how do you get the government to understand that these policies of change about women are decades, centuries overdue? And so I really want to thank y'all for the time. I also want to thank the attendees for tuning in. And I would just want to remind you that the next session, if I can talk today, begins at 12 noon after a brief break. So I want to just sort of thank everyone.
Thank you.
Thank you.